on thalassemia. So that was the last topic on anemia. Just we're going to do a quick summary on thalassemia before we go back to the leukemia we have started. So we have talked about the genetic disorder of hemoglobin. We have started by sickle cell. Then now we are going to talk about briefly on thalassemia. So thalassemia, which is a British spelling, it also inherited autosomal recessive blood diseases, which now is due to reduce on the synthesis of one of the hemoglobin chain. It might be alpha or beta chain. So that's abnormality of the hemoglobin chain make the red cell to be abnormal, and they may be destroyed earlier and cause anemia. So thalassemia is somehow quantitative problem of few synthesis of hemoglobin, while sickle cell is a qualitative issues. So on the world, around hundreds thousand of the babies are born with severe form of the disease every year. So the prevalence mostly we come out to separate by the type of the disease. Is it A or B? But the prevalence is somehow higher in the Mediterranean countries, mostly in Italy, in Greek. Then we have again two types of thalassemia, either alpha, when the alpha chain is reduced in production, or beta chain. So let's start by alpha chain. It's usually seen in southern east of Asia, Chinese and Filipino. There will be decrease in alpha globin chain, where there will be few alpha chain cells produced. It's a genetic disorder where it will involve the gene ABA1 and ABA2, which is inherited in Mendelian recessive fashion. I think we have done it in genetic with more details. So the deletion will be on the chromosome X16, 16p. Then there will be excess of beta chain formation that will be in stable tetramers when they call it hemoglobin H, which have abnormal oxygen dissociation curve. So for the genetic coordination, we have four loci, which is two from the maternal side and two for the paternal side. The severity of this alpha thalassemia will depend on which loci is affected among the four. So if one of the loci is affected, that one will cause really minimal effect without clinical manifestation, as the three loci will be able to produce enough of normal hemoglobin. So that's one, there will be no symptoms, there will be no anemia. So those people who have one issue on the one loci are called silent carriers. They may only have decrease in MCV and MCHC. Next will be if the two loci of the four are affected, the condition is called alpha thalassemia trait. So again, this group will have nearly normal erythropoiesis, but the patient may present mild hypochromic microcytic anemia. Sometimes because they are all microcytic hypochromic, they are mistreated like a iron deficiency while not being iron deficiency. So we have alpha thalassemia traits, which exist in two forms. We have one form which is associated with Asian and another form which is associated with Black population. Next will be if the the trilogy are affected, the condition is called hemoglobin H disease. That's where there will be two unstable hemoglobin, hemoglobin BART, which is really associated with the tetrameric presentation of hemoglobin chain. So we have hemoglobin BART and hemoglobin H. So this will be a stable hemoglobin with high affinity to the oxygen, which results uh, poor oxygen delivery to the tissue. So that will be a severe form of the thalassemia. This can be seen in the peripheral blood field when you see target cell, or we see precipitated hemoglobin. You see hands body. On the peripheral blood field, you can also see future of hypofunctioning of the spleen by looking what you call holy jolly bodies or target cell, which were supposed to be removed by the spleen in case the spleen is functioning very well. So lastly, if the follow-chi is affected, that will be a condition we call hydrops fetalis, where the fetus cannot survive outside the uterus. Normally they die in uterus. So the child may be born and died after delivery as they cannot be supported outside. So we have beta thalassemia, which is also a genetic issue like the first one. Now it's on the chromosome 11. The mode of transfusion is autosomal recessive fashion. Again, it will be depending on how the mutation is characterized. There is a thalassemia beta 0 in case there is prevention of any presence of beta chain. So it means no beta chains. There will be second one will be beta plus, which may allows the production of few chain of beta. So compared to the first thalassemia alpha, now even if there is decrease in beta chain, there is no tendency to form of for tetramer. So now for the beta thalassemia, there are two alleles which are bearing the mutation. If one of the B globin allele is bearing the mutation, that will be a beta thalassemia minor or beta thalassemia trait, which will be presenting mild macrocytic anemia. Then in most of the case, it will be minor or even sometimes asymptomatic. The patient may spend the life without noticing that they have anemia because the anemia is really a mild one. So we didn't discuss on the mild classification of the anemia. We have severe anemia when the anemia is below 7 grams per deciliter. We have moderate anemia when it is above 7 to 10. Then between 10 and above, that will be to the normal range, that will be mild anemia. So when I say mild anemia, hemoglobin range is between 10 to 12. So meaning lower limit and from 10. So when the two-loci allele is affected in beta thalassemia, that will be called thalassemia major or Coulé's anemia. Coulé was the one who described it for the first time in 1925. So beta thalassemia major will be manifested by severe microcytic hypochromic anemia. When it is not treated, it might progress to death before the age of 20. So all the type of this condition usually they required it's a chronic condition. They require the multiple episode of a blood transfusion. By this, they may also develop splenomegaly. When the splenomegaly is huge, it will be causing hypersplenism, reducing the blood count. So in that condition, you might do splenectomy. Again, the cure is possible after bone marrow transplantation. So there's another condition which is called thalassemia intermediate, which is somehow intermediate between major and minor form. But when you go to the background of this, it's manifested by diverse number of different mutation that may cause either reduce or absence of beta globin synthesis. Yeah, so that is thalassemia media. So again, I will say about the transfusion. What when the patient is on the transfusion for several times, we need to give iron chelator. There is no physiological mechanism to excrete the iron excess from the body. So when you're transfusing the patient, you are increasing amount of iron in the body. So let's say 300 mils of for bloods, red blood cell increase like around 30 mils of milligram of iron. So 30, 300 milligram of the iron. So massive blood transfusion or regular blood transfusion expose the patient to iron overload. Then sometimes the carrier may have benefit of protection against malaria. So I have said about sickle cell. So that was just a small summary on genetic disorder of thalassemia. If there's no question, that's all on anemia. So what we need to remind on anemia. So among the hematological diseases, anemia is the commonest. The anemia can be primary the cause from the bone marrow, but most of the time it secondary to systemic diseases. We have spoken about anemia of chronic diseases. Then also remember anemia due to micronutrient deficiency. We have talked about iron deficiency. We have talked about vitamin B12 and folic acid deficiency causing megaloblastic anemia. Remember to do a good investigation of anemia and remember to address the cause of anemia. What I can say, anemia is not a diagnosis. If I say, what is the diagnosis for this patient? You can't reply to me, this is anemia. So anemia, again, it's due to something. Don't stop there. Anemia is there, but try to find out what is causing anemia and treat the causes. If you find the patient with the iron deficiency, again, iron deficiency, what is the cause of this iron deficiency? And treat it and supplement the patient in iron deficiency. So again, the underlying condition should be addressed and respect the treatment duration. So if the patient is having iron deficiency, remember again, the goal of the treatment is not to raise only the hemoglobin, but also to replenish the storage of iron. So remember testing ferritin when you're treating iron deficiency and treat at least 3 to 6 months so that the patient is somehow well, having well storage of iron. For vitamin B12, we have said about pernicious anemia, while there is a autoimmune destruction of Pareto cells, so decrease in intracell factor, which is supposed to play a role in the absorption of vitamin B12. So when it's the disorder is like that, the patient should be treated intramuscularly, not orally, as there is a poor absorption. Then the treatment should be continued to for lifetime, for lifetime. So consider that the treatment is depending on the state of absorption, the diet, and all this. Then in iron deficiency, remember already if you have iron deficiency, you have to screen for the bleeding. Some people may bleed on the GI without knowing that. So again, remember to do more investigation. When you don't see clear cause of iron deficiency, you can request for upper GI endoscopy, colonoscopy to find out if there is no iron loss through chronic GI bleeding. So again, on the investigation of anemia, remember to do systematically. Everyone with anemia request for reticulocyte count, request for peripheral blood film, and for this, for now, as our setting, we have a high number of people with the macronutrient deficiency. We are now screening for all. We have to screen for iron deficiency, to screen for folic acid deficiency, and vitamin B12 deficiency. For the rest, the investigation plan will be depending on the initial initial feedback from the peripheral blood film. If there is future of hemolytic anemia, you have to go deeply and find out what kind of hemolysis is going there. If it is in a plastic anemia, again, remember when you don't see any evident cause of anemia, you have to go for the bone marrow aspiration biopsy, which will give you somehow more details about the cause of anemia. So remember plastic anemia, remember sideroblastic anemia. So all these should be made through bone marrow biopsy or bone marrow aspiration. So if you have any question on anemia, you're welcome to ask it. Then we'll continue with the uh, disorder of the white cell. Any question on anemia? Any question? Do you have any question on anemia? Are you following? Oh, I'm alone. Any question?
We are following. We don't have a question. Can proceed.
Okay. So if there's no question, let's proceed then. We have talked about leukemia, and let's now discuss what is myelodysplastic syndrome. So, myelodysplasia, myelo mean marrow in Greek, then this mean irregular, then plasia mean proliferation. So when they talk about myelodysplastic syndrome, it's really a group of the disease which varying between active and abnormal proliferation of hematopoiesis in the bone marrow, whether with acrosechronia and delayed in maturation of different cell, then also early apoptosis, which may lead either to peripheral blood cytopenia or to ineffective hematopoiesis. So in summary, what I can say from this, it's just when the bone marrow is not able to produce the adequate number of blood cells that will be cytopenia, but only it may also produce abnormal cells that we say asynchrony between the maturation of different lines. Again, remember if I say myeloid cells, remember that it's all of the blood cell except the lymphocyte. So there'll be bone marrow failure to produce qualitative, that may be like a cell morphology, and quantitative, meaning cell numbers. So that will lead to ineffective erythropoiesis. So by this, usually the cause, it usually affects all the myeloid cells, starting from the erythroid, myeloid, and megakaryocyte line will be affected. So it may be an acquired diseases with starting from the stem cells, where it express CD34. Those are the monoclonal antibody expressed by the cells. Then addition to the peripheral cytopenia, it also there'll be like a component of hemolysis, meaning that there'll be shortness of the survival of some of the cells, which called uh, causing cytopenia of the decrease in count. So this can be occurring uh, on the patient, that may be manifested by decreased production of a platelet causing bleeding, decreased production of neutrophil causing high exposure to infection. So it was earlier called refractory anemia, which was somehow called like a preleukemic status, meaning people may develop fast myelodysplasia and let alone come out with anemia. So then later way they have described another diseases, another component of the disease called myeloproliferative disorder, where there will be excess of production of myeloid cells. Yeah, so myelodysplasia usually represented by pancytopenia. They may also present with the huge splenomegaly, as sometimes the bone marrow is not able to produce the cell. Then the spleen can take over, trying to compensate the role of the bone marrow, that may cause enlargement of the spleen. So the French American British classification, which focus on differentiating myelodysplasia from myeloproliferative disorder. So from myelodysplasia, we have refractory anemia, that's number one. Secondly, we have refractory anemia with sideroblasts. That is the one we have talked about yesterday. We have seen that the diagnosis is made by looking at the ring sideroblasts from the bone marrow. Then refractory anemia with excess of the blast. Remember, the blasts are the one we have seen, the earliest myeloblasts. So there will be excess of the blasts. Then we have the type of refractory anemia with excess of blast in transformation. So that will be like almost leukemic stage, acute leukemia coming soon. Then lastly, we have chronic myelomonocytic leukemia, which will be leukemia affecting the monocytic line. Then from the myeloproliferative disorder, if I say myeloproliferative disorder, you understand the increased proliferation, increase in number. First on the list, we have a polycythemia rubra vera, meaning excess production in the red blood cells. We have essential thrombocythemia, meaning increase in production of thrombocytes. We have idiopathic myelofibrosis, meaning that the bone marrow will be changing the structure, becoming fibrotic tissue. Then we have myeloid metaplasia. That is myelofibrosis again. Then the last one will be chronic myelogenic leukemia. So that's one we are going to start now. So there is still somehow the two disorders being myelodysplasia or myeloproliferative, they have some common, where all of them may transform to acute myeloid leukemia. So you can get acute myeloid leukemia from either myelodysplasia or from myeloproliferative disorder. Those are the, the common thing they have together. So based on the etiology of and the pathogenesis of the disease, there have been several genetic abnormality described in myelodysplasia, where we have either genetic mutation and abnormal DNA repairments, which may be seen when the age advanced. But also we have some hereditary predisposition, people with like Fanconi pancytopenia, Down syndrome, familial monosomy 7. Also, these are risk factor to develop myelodysplasia. But apart being genetically or hereditary type, we have also acquired one, which may occur after chemotherapy. So cancer treatment may also induce myelodysplasia. We have exposure to radiation, exposure to chemicals like benzene. We have post-bone marrow transplantation, also from paroxysmal noctimoglobinemia with clonal expression, where there'll be cell hypersensitivity to complement. So again, that condition may be uh, acquired. So myelodysplasia, we have said then the cells may be destroyed before the normal lifespan. So there'll be early apoptosis in the bone marrow. By this, it may be either uh, there is a myelodysplasia clone with a oncoprotein proliferation, but also uh, the bone marrow microenvironment may be also the risk factors. So we have seen how we have classified the myelodysplasia. We have refractory anemia. We have refractory anemia with the ring sideroblasts, excess of blast, and excess of blast in transformation. So this is just showing you that the most common is refractory anemia with excess of the blast, representing 37%. So this is quite the different type of myelodysplasia. This is the table classifying the type of myelodysplasia, refractory anemia with the ring sideroblasts, excess of blast and transformation, all this. Then they give you the percentage of the number of the blasts seen in the peripheral. So when you see the last type, which is a refractory anemia with excess of blast in transformation, that's almost getting to the stage of leukemia, so acute leukemia. So we have said that acute leukemia, the number of the blasts are above 30% but this stage it's somehow the previous just below the cutoff of acute leukemia. So clinical manifestation of myelodysplasia might be non-specific and they're varying depending on the symptom, depending on the types of the cells which are affected. The patient may be mostly asymptomatic. Then just go for the lab and found that the patient is having a future of myelodysplasia. They might have a future of fatigue, dizziness, weakness because of the anemia. They might bleed due to thrombocytopenia. They might have white loss and so on. Then they may also have infection, which might be the key things which may kill your patient. So sometimes they may also present future of autoimmune hemolytic anemia, which we are really very rare. Hepatosplenomegaly may also be present, but they're usually for chronic myelocytic leukemia. They may also have a cutaneous manifestation. They may have a purpura and so on. So if you remember, they may present as people with also leukemia. So myelodysplasia, we have a laboratory classification. You have to consider to check for the full blood count, which may show you macrocytic anemia with the different variation in shape and size, which you call anisopoikilocytosis. They may also have to check the the level of vitamin B12, because we have said that in B12 deficiency and folic deficiency, we have ancychronia in maturation of a nucleus and the cytoplasm. So as I said, myelodysplasia, you may also see abnormal cell morphology. So you have to screen for this deficiency. So you may also see what we call leukoerythroblastosis, which means liberation in the peripheral blood film, immature red cell and immature white cells. So you see the cells which are supposed to be in the bone marrow, which are released in the peripheral blood film with excess. So other cells are there. You may see some things else. So from the how do you test for it? You have also to screen for paroxysmal nocturnal hemoglobinuria, where you may see CD 55 and CD95 positive for this PNH. The rest are just. So, how do you make the diagnosis of myelodysplasia? We may see persistent cytopenia with non-morphological normality. So, you may also see others with normal or macrocytic anemia without deficiency in B12 or folic acid. You may also see hyper or hypocellular bone marrow with the megaloblastoid. Megaloblastoid, again, remember immaturity asynchronia between the maturation of the nucleus and the cytoplasm. So then you have also to measure the number of the blasts. So when you found that the CD34 is positive, then you have confirmed that those are the blast cells, and then you count the blasts. It helps you to classify which type of uh, myelodysplasia you are dealing with that. So differential diagnosis, again, megaloblastic anemia, plastic anemia, myelofibrosis, chronic myeloleukemia, all these are the type of the diseases you may make the differential diagnosis to exclude all of them. So how do you treat it? Most of time we require no treatment. You just follow the patient. If there is need of transfusion, you may transfuse the patient. The chronic anemia may cause a chronic heart failure that should be considered. Then consider giving some growth factors like granulocyte colony stimulating factor or erythropoietin, which may help also to support the patient. But sometimes this growth factor may accelerate the leukemic transformation. So remember again, when you are transfusing patient for a long time for continuous transfusion, you may cause harm to have iron overload. So remember, 250 ml of the red blood cell contain 250 ml of iron. So when you give it several times, while we don't have any physiological mechanism to decrease the iron, that will cause iron overload. So again, the iron deposition may be affecting some of the organs. We have the spleen, the liver, the heart. And you have to remember the ion chelation by giving the molecules which will be decreasing the ion. Alloimmunization, we may have people developing alloimmunization after blood transfusion. And also remember you may decrease the lymphocyte T lymphocyte after giving several times the transfusion. So sometimes we may give chemotherapy to those patients, those the list of the treatment, but also you can also give allogenic stem cell transplantation, or you can also give immunosuppressors with ATG, which has shown successfulness. So that was just to explain how myelodysplasia can precede the development of leukemia, but all myelodysplasia can just be there for a long time. So you can make the diagnosis of myelodysplasia when you do your bone marrow examination. You don't see evident causes seen. You see abnormality of the cell, and you don't see any clear cause of the disease. So let's go now to chronic leukemia. So we have discussed about acute leukemia. We said acute myeloid and acute lymphoblastic leukemia. Now, brief discussion on chronic. Now we have a chronic myeloid leukemia and chronic lymphocytic leukemia. By this, we have to understand how do we diagnose chronic leukemia, what are the risk factors, how the presentation of clinical presentation, and how do we treat it. So leukemia, we have said the classification. That's just a repetition. So that's now the clonal proliferation of the white cell, which is characterized by increased proliferation of a granulocyte line without the loss of their capacity to differentiate.
We
So
can't see the
where
slide.
oh, transmission. Can you see it now? Can you see?
Yes.
For me, I can't see it.
You can't see it.
It is visible. We can see it.
Okay. So here I was saying that compared to the acute leukemia, there is a maturation loss. So the cells lost the capacity to maturate. But here the cells are there, they continue to maturate and differentiate. So there will be increase in the myeloid cell, increase of erythroid platelets in the peripheral blood with the marked myeloid hyperplasia in the bone marrow. So it's really originated in the single abnormal hematopoietic stem cell, which is the the myeloid stem cell. So you can call it chronic myelocytic leukemia, chronic myelogenous leukemia, or chronic granulocytic leukemia. When you say all of this, it's the same. This again, the image we have to focus on that when we are explaining. So we have the pluripotent stem cell is not here, but you start by the myeloid stem cell. Myeloid leukemia will take all of these myeloid cell wakuyemo lymphocytes, lymphoid stem cell. So from the chronic leukemia, we have a myeloid stem cell which will develop to myeloblasts. Myeloblasts, when it is in acute leukemia, there will be maturation arrest at stage of the myeloblasts. But for chronic leukemia, the myeloblasts will keep maturating and differentiation. Normally, the mitosis is done up to the stage of a myelocyte. Then from the myelocyte, there's no longer division, it's just maturation of the cells. Now from the chronic myeloid leukemia, the cells will be maturating up to the neutrophy stage. But when you look on the peripheral blood, you may see mostly increase of the neutrophil, bands, and metamyelocyte, but also you may see all this stage of maturation in the peripheral blood film. So what is the mechanism of the disease? The mechanism of the disease, it usually based on the fusion of two genes. So we have a BCL on the chromosome 22, on ABL1 on the chromosome 9, which is a Philadelphia chromosome, where we have the fusion of the two. The fusion of these two chromosomes has tyrosine kinase activity. So this is the image, the long arm of a chromosome 9 at ABL, leaving that one and going to meet the long arm of chromosome 22, causing the fusion chromosome, which has the capacity of tyrosine kinase activity, which has the capacity to produce in control proliferation of the cells. That is the mechanism behind the CLL. CML. So I'll be saying CML. CML means chronic myeloid leukemia. So that should be clear. So this fusion has the oncoprotein, which has an enzyme activity of tyrosine kinase, which in vivo activity is greater. Then there will be abnormal proliferation of the cells. The cell will be living longer, delay in apoptosis, and so on. So people with CML will present 90 to 95% will have this chromosome, Philadelphia chromosome. Just few of them, around 10, 5 to 10, will have chromosome, Philadelphia chromosome negative. So having the mutation of chromosome Philadelphia is somehow having better prognosis because we have the treatment. The treatment is now focusing on the inhibition of tyrosine kinase activities. So BCL, which means big point cluster region, will be fusion to aberration leukemic virus on the gene on chromosome 9. Then this Philadelphia chromosome will be found in myeloid, on monocytic and erythroid megakaryocytes. That's why in case of CML, you may see all of those cells increasing together with the production of the myeloid cells together. So you may see someone with the increase of the platelets, normal anemia, or even increase just because the pluripotent activity affects all the myeloid cells together. So that is epidemiology. It usually affects, it is 15 to 20% of all leukemia in adults. Then it tends to increase these days. The annual incidence is 1 to 2 cases per 100,000 population. And then it's also somehow having increased incidence and having male predominance. So these days in Seashika, in Rwanda, Seashibe and Kigali, we may have 30 cases per year, but that was around the 2015. But now I can say that not that was before, but these days we are having a lot of cases of leukemias. We are now trying to find out what is going on. A lot of cases of leukemia these days. It's now better to do studies to know what are the risk factors. So looking at this table, you see starting from the age of minus below than 1 up to 85, you see that the prevalence of CML increase with the age, being higher above 80 years old. So risk factors of CML, we have exposure to high dose of radiation. Again, radiation is coming back for all type of the leukemia, but here again, it's mostly the one sitting CML, exposure to atomic bomb, high radiation, when people are getting cancer treatment, but also exposure to the diagnostic data or medical X-ray. That's why don't send your patient for repeated X-ray, CT scan, or if there's no evidence, any supportive clinical element. Several X-rays may cause high risk of exposuring to the radiation and causing chronic leukemia. So it's really a slow grade growing diseases that may interfere with the development of the red blood cells, white blood cell, and the platelets. 20 to 50% of the cases are asymptomatic. The patient may come to you just for routine checkup, that when you may diagnose the CML. So the symptoms now will be depending on the phase of the diseases. Here we have 3 phases. We have chronic phases, which is representing 85%. Chronic phases may be routinely diagnosis while the patient coming for other condition, ashobora kuza afite malaria cyangwa se afite check-up akaza mukasanga afite leukemia. Otherwise, the second phase is accelerated phase, where the patient will be coming for high leukocytosis, thrombocytopenia, even worsening of the diseases if there is no treatment. Then we have blast crisis. Blast crisis, it's the progression of the diseases when there is no treatment. So blast crisis, chronic myeloid leukemia may transform to acute myeloid leukemia in 70%. Then in 30%, they may turn up to be acute lymphoblastic leukemia. So again, the symptoms, you see that in the chronic phase, the patient may have increase of thrombocytes or normal thrombocytes or even normal hemoglobin. Then again, that's a phase, that's when there'll be severity of the diseases. So this is the clinical manifestation of the disease. We have fatigue due to anemia, we have platelet dysfunction, closing bleeding, and weight loss, abnormal fullness because of the splenomegaly, and so on, night sweats, and so on. Splenomegaly will be common in most of the patients. I can say around even 80% of the patient will present with the splenomegaly, or then the anemia around 45 to 62. So compared to acute leukemia in CML, the counts, the full blood count, the white cell count will be extremely very high. Some of the patients may come with a count of 200 something. So most of the time it will be above 100, but most of them may come with 200 and so. So the count is very high. What is opposite of, again, the platelet count might be normal or increased. So if you see someone with increase of white cell extremely increase with huge splenomegaly, then the platelet is somehow normal or increased, that's one oriented to chronic leukemia. Acute leukemia, it's an abrupt process, bone marrow failure to produce other type of the cell. The patient will present with like thrombocytopenia. So again, looking on the count of the white cell, looking at the level of the platelet may help you to say this must be an acute leukemia and the disease history. So again, take the history. He may say, since last year I'm feeling this. So again, that help you to really so you may have lymph node, skin, and soft tissue, which may be seen when the patient is having blast crisis. So this is the chronic disease with the splenomegaly. The splenomegaly are usually massive. They have anemia. They may have, despite having the normal platelet count, they may have platelet dysfunction causing the bleeding. They have hyperleukocytosis, which may produce the risk of thrombosis, the risk of increased breakdown, causing gout or visual dysplasia and priapism and so on. So how do you make the diagnosis of CML? It's just looking at the full blood count. You see marked hyperleukocytosis with the marked shift to the left. Shift to the left means you are seeing all the stage of white cell maturation from the blast to the neutrophils. So you see myeloid, you see promyelocyte, myelocyte, metamyeloid, all of them are on the peripheral blood film. Then if it is in chronic phase, you'll have tendency of increase of neutrophils and bands. If it is in acute phase, you'll be having tendency to having more blasts. So depending on the case you are looking, that will show you. The anemia may be normocytic, normochromic. Then the platelet can be normal or elevated. That is the slide how it look like. So there will be things like that. So increase of you see on the slide we have a band, mostly band, and we have blast, we have myelocyte. So everything together, but when you look on the number, it really you increase number. On the image here, we see myelocytes. You see myelocyte, you see neutrophil, basophil, and metamylocytes. They are all somehow mixed together, but also we have tendency to increase of basophil. So how do you know if it is how do you know if it is in a chronic phase, is it in acute phase, or it is in accelerated phase? So the phase usually depends on the number of the blast. Blast, if it is below 10% myelofilm peripheral on the bone marrow, in the peripheral blood film, that will be chronic phase. Accelerated phase when the blasts are between 10 to 20%. Then blastic crisis, it's like going to acute leukemia, there will be increase of myeloblasts. So that is how you can classify your patient on that. Bone marrow, there will be hypercellularity, there will be myeloid erythroid ratio increased. Normally it is 2 to 1, but here you'll see 10 to 1. We have myelocyte predominant cell with blasts less than 10%, that is chronic phase. Megakaryocyte will be increased. There will be also increase of reticular lymphofibrosis on that one. So we have neutrophil alkaline phosphatase will be reduced. Neutrophil alkaline phosphatase, it's a test to measure, to do the difference between leukemioid reaction and CML. There is a condition we call leukemioid reaction, mean that there is a production of the white cell response to the stress, either inflammation or infection to the body. The bone marrow reacts by stress and producing excess of the white cells. So then you may also see some immature cells. So slight left shift, you may see bands and metamyelocytes. So when you do neutrophil alkaline phosphatase test, it will stand more in leukemioid reaction, but in case of CML, it will be same. So the score will be less in case of CML. You may see increase of B12, the vitamin B12, uric acid increasing, and LDH increasing as we are having cell turnover by destruction of the cell and so on. Then the key element to do is to do the cytogenetic, which will be searching for the Philadelphia chromosome. You will go for peripheral blood film, you will go for neutrophil alkaline phosphatase and bone marrow cytogenetic to make your full diagnosis. So what is depending on the survival time will be depending on the phase of the diseases. Median duration is 3.5 to 5 years before evolving to more aggressive phases. Then you may find increased splenomegaly refractory to the chemotherapy, increasing chemotherapy requirements. Then the lab will tell you which is the amount of the blast and so on. Blastic phase, we have said that. Again, what I can say, 2/3 of the CML will transform to acute myeloblastic leukemia and 1/3 will transform to acute lymphoblastic leukemia. So when there is transformation to blastic phase, the survival time is one of the leukemia, acute leukemia, which means 9 months versus 3 months. So shortness of the survival time when there is acute leukemic transformation. How do we treat it? The treatment first will depend on the genetic abnormality. If the patient is a Philadelphia chromosome or negative, then you may do cytogenetic analysis, or we can use also FISH, which will show you if there is a BCR-ABL fusion. So the three goals of the treatment, it's hematological remission, meaning the count recome to normal range and there's no more splenomegaly. There will be cytogenetic remission with 0 positive Philadelphia positive cells. Then you have also the molecular remission resulting from the mutation. So you have to have negative PCR. So probably what do you need to do when you have your patient, you are suspecting CML? For now, the patient will have hyperleukocytosis. There will be future of hyperviscosities with headache, blood vision, sweating, and something like dizziness, something like that. What you need to do, you have to do to hydrate your patient. You give a lot of fluid. You have to give them chemotherapy to decrease the count of the white blood cell. Then, if the patient, after getting the result from the cytogenetic, the patient is having a positive Philadelphia positive. So we said that the fusion BCR-ABL has tyrosine kinase activity, which is stimulating the proliferation of the cells. So we have to give inhibitors of tyrosine kinase activity, which is imatinib. So imatinib, it's tyrosine kinase inhibitors, which will focusing on the fusion. So in the past, for those who are positive for Philadelphia are the one receiving tyrosine kinase inhibitor, but those who are negative, the low proportion of negative Philadelphia negative, those are the patients who will make challenge in the treatment, but also they have not good prognosis. They might be the patient for bone marrow transplantation. They may get hydroxyurea or alpha interferon for their treatment. Busulfan was given in the past. Again, if the patient is Philadelphia negative, he may go for busulfan, but those who are Philadelphia positive usually go for imatinib or tyrosine kinase inhibitors. Hydroxyurea, again, you can give it in case the patient is Philadelphia negative, but also if he's still waiting for the cytogenetic test. You can also combine human alpha interferon, which may also give a good response, especially for those who are Philadelphia negative. So what was the survival time? It's usually around median is around 3 to 5 years. With interferon, they have 6 years. Then after transplants, they have more than 5 years. By giving tyrosine inhibitors, they're now saying that the survival time is almost 95% as people without leukemia, without CML, meaning that the imatinib was introduced like 20 years ago. It's still early to say the survival time of imatinib, but now we understand that studies are now saying that it's around 95% as normal people. So there's really, that's why I'm saying having a Philadelphia chromosome positive, it's somehow good news to a patient having CML. So it really give good response. So that is all about chronic myeloid leukemia. Let's go quickly to chronic lymphocytic leukemia. Then you have question if you have any. Chronic lymphocytic leukemia. Uh, it's now also characterized by the neoplastic proliferation and accumulation of lymphocytes, which are usually mature lymphocytes, but the lymphocyte we are seeing here will be non-functioning, so they are dysfunctioning lymphocytes. So they're not playing their usual role as producing immunoglobulin. So they are clonal B cell malignancy. Usually, they cause progressive accumulation of long-lived mature lymphocytes. There'll be increase in anti-apoptotic protein BCL2, meaning that the cells are living longer compared to the normal lifespan. They're mostly expressing monoclonal B lymphocytes, which are CD positive. Then there is an intermediate stage between pre-B and mature B cell. You can also have a chronic CLL with the T lymphocyte, which is really very rare. CLL is really common in Western worlds and less frequent in Asia and America, but also not common in Africa. The male to female ratio is 2 to 1. It's a disease of the old people. You usually see it around above 60. It's really uncommon in patients under 50 years. So in US population, the incidence is similar to different races. The cause of CML is somehow not known, but it somehow increased in people manufacturing asbestosis, people who tire repair workers, and also farmers. So these are the group of the people who might have high risk of developing CLL, but also they speculated that there is also genetic factors in some families which may also be associated with the development of CLL. So among them, we have 50% may have chromosome abnormalities. Among the mostly, we have trisomy 12. We have structural abnormality in chromosome 13, 14, and 11, which may be seen, but also We have difference of oxygen, which may be also involved with the having the same as tyrosine kinase activities as CML. So how tell the symptom of CLL is it's like the first CML, some asymptomatic patient may be present in 40% of the cases. Just patient may come for routine test, then you find them having a CLL. They may most of time complain of the fatigue, well syndrome, which means increased sensitivity to insect bites, but they may also present with B symptom like a fever, sweat, and weight loss. The initial complaint may be also enlargement of the lymph nodes, which may be there, but also they might be having risk of infection. Clinical finding, we may see an enlargement of the lymph nodes, commonly seen in cervical and supraclavicular. Most of them will have splenomegaly. Also, hepatomegaly may occur, but rarely they may present feature of anemia and bruising. As I said from here, it's a progressive diseases. The bone marrow is maturating very well. The cells are there, but you may see the difference between acute one. So how do you make the diagnosis? You go to the lab, you found that there is increase in white blood cells, mostly lymphocytes, raising above 5 grams per liter. For 4 weeks don't change. They have a monoclonal population of small mature lymphocytes. So those are mature lymphocytes which are really morphologically normal. They mostly have expressing B cell, which have CD5 positive and CD19 positive in the flow cytometry. They also have a kappa and lambda chain restriction, which is also seen on the immunoglobulin. They have on the bone marrow, you see that more than 30% are really lymphocytes. Then on the lymph node, they may be having increase of the lymph node. So what is somehow consistent with the CLL, it's just the slides we have the form which are called basket cell or smooth cell. Basket cell, those are the lymphocytes which are fragilized. When you do this blood smear, the lymphocytes are destroyed. So that is the image we call basket cells, which are or smudge cells, which are seen in the CLL. So by doing your carefully full examination, full blood smear evaluation, you can also do the differentiation through flow cytometry. So this is the lymphocyte we are seeing. The smooth cell are the cell here you are seeing, which are somehow destroyed without, you see that most of the cell are lymphocytes. The one here down is a neglected red cell. You see the cytoplasm of the red cell with still having nucleus. Then the smooth cell are those cells which are somehow imagine a déchet cyangwa se destroyed one. So the B cell are thin cytoplasm. They have dense nucleus. They have partially aggregated. Then you don't see any nucleoli. Then you see the smooth cell there. So we have a clonal expression of B cell, which represents 9% and T cell 1%. Then there'll be the B cell are the one producing immunoglobulin. Then we have light chain of hemoglobin, which will be there. Then remember flow cytometry, which show you CD19 and CD5 positive. That is immunophenotyping. We're not going to details because we don't have it locally, but also at your level, you don't need to go deeply. So remember in flow cytometry, they say CD5 and CD19 positive. Other lab to do is to have hypogammaglobulinemia, which is often observed. People with the CLL, 10 to 25% will have autoimmune hemolytic anemia with Coombs positive test. So again, the mechanism of anemia might be either autoimmune hemolytic anemia or just the bone marrow failing to produce the red cell. Then when you go to the bone marrow, you may see 30% which are really lymphocytic cell. This is the bone marrow. The cell are mostly small lymphocytes. We have decrease of neutropenia, we have anemia and thrombocytopenia. They might have extramedullary expression, splenomegaly, hepatomegaly, and lymphadenopathy. This is the lymph node biopsy, where you have a diffuse infiltration of small lymphocytes from the lymphadenopathy. So this is the three things to consider to make the diagnosis of CLL. First of all, focusing on the number of the lymphocytes seeing. So more than 5 grams per liter with less than of 55 being atypical cells. So those are really mature lymphocytes. On the flow cytometry, the cells are expressing CD10, mostly CD5 and CD19 positive. Then when you go to the bone marrow, 30% more, 30% or more are small lymphocytes. So differential diagnosis, we have bacteria origin. So you have to make the difference if it is either coming from the bacteria infection or viral infection. Don't confuse them because I think in CLL you have to take the history. You have to take the history of the patient and to consider the physical examination and so on. So also the number of the white cell count which would be more increased. So malignant causes, consider B cell lymphoma, non-Hodgkin lymphoma, and so on. So differential diagnosis will be lymphomas. This is the classification of RAI staging system, which put the patients on which stage, because the stage of the disease will help you to treat your patient, but also to predict the prognosis. So stage 0, the patient come to you just with lymphocytosis, just increase of lymphocyte without any issues. Stage 1, he has lymphocytosis with enlargement of lymph node. He has intermediate risk. Stage 2, lymphocytosis. Now he has also hepatomegaly or splenomegaly plus enlargement of the lymph node. Stage 4, lymphocytosis, anemia, hepatosplenomegaly, and enlargement of the lymph nodes. Then stage 4, he has also thrombocytopenia. So you see that anemia, thrombocytopenia come really at advanced stage. At the beginning, the patient is stable without anything. So that is how the disease progress. So this is just the progression of the diseases, considering the right stage. You see that the 0 has probability of survival longer than the one in RAI 1 and 2. So RAI 1 and 2 are in the middle, then RAI 3 and 4, the survival time is lower. So meaning that the stage of the disease predicts the survival time. Binet's one is usually almost the same as the RAI one. It's just combining a stage A, 3 area of the enlargement lymphoid tissue. Below that, then B is above enlargement of the lymphoid tissue. Then C, when there is anemia and thrombocytopenia. So now here you have to consider what is the area having lymph nodes. Is it cervical? Is it axillary? Is it chest? Is it abdomen? All these should be considered reclassification. Then the BNet also are the same, saying that BNet A and B and C the prognosis will depend on that. So again, this is somehow combining Rai staging and Binet staging by seeing the survival, major survival time. We have spoken that. So what are the markers of a poor prognosis? It is adverse or Rai and Binet stage. Peripheral lymphocyte doubling time in lower than 1 on 12 months. Diffuse marrow histology, but also increased number of prolymphocyte or cleave lymphocyte. Poor response to chemotherapy, abnormal karyotyping, or increased beta-2 microglobulin level. That is the histology, how it look like. When you do the bone marrow, you see that in the biopsy. This has the cytogenetic abnormality starting from the one which are unfavorable coming to the one who are favorable. So from down to going up, better prognosis to poor prognosis. Then this is how we see it. Lymphocyte doubling time also is among the factor of poor prognosis. Then genetic abnormalities, we have said about it. You see on that. We have the disease progression. We'll be having the patient may have variation in the progression. People may spend years without evidence of disease progression to one who may have also progression to generalized lymph nodes. They may progress to bone marrow impairment with susceptibility to infection. The complication will be then bleeding due to decrease of the platelets, but also infection will be the major cause of death in this population. So CML complication, we said that some of them will develop 10 to 30% will develop autoimmune hemolytic anemia. You have to do Coombs test to rule out that. They may also develop pure red cell aplasia. You may also develop what we call immune-mediated thrombocytopenia, also on granulocytopenia, decrease immunoglobulin with advance of the diseases. Then they may also have other phenomena coming from that. These are the complications. They may also complicate to acute leukemia and so on. So treatment is really based on palliation. The age is the factor on that. As we said, most of the patients may have 60 years or old. So to sometimes you may decide not to treat the patient because considering the age of the patient, considering the complication of the chemotherapy and the disease progression, sometimes you just decide to watch the patient and see how they progress. What else we have? We have to consider to treat the complete remission, where the patient will come with the normal full blood count, to eliminate the minimal residual diseases, but also to predict more survival time. So first of all, it's watch and wait, meaning that you assess the patient, you see the patient is in stage 0, just lymphocytosis without lymphadenopathy, without anemia, without thrombocytopenia. You say, okay, you have the leukemia, go home and come back in 6 months, in 3 months. So you just wait and watch and wait. That's also possible. Secondly, you can decide to give a steroid, but also you can give alkaline agent like chlorambucil, cyclophosphamide. You can also give a pain analog like fludarabine. That's also possible. Then you can also choose to give a combination of the treatment depending on which stage is the patient. You can also give monoclonal antibodies, which are really focusing on anti-T, anti-CD20. That's among the gold standard treatment, and you can also decide to do splenectomy if the spleen is huge, causing hypersplenism. Hematopoietic stem cell can also consider, but also can also do autologous before starting chemo. You get the stem cell from the patient. Then after the chemo, you can introduce the same. So for the chemo treatment, the reason why I'm not giving the protocol, as I say, chemotherapy protocol depends on the setting. Most of the time, there are new molecule coming on the markets. You have to consider your patient, the capacity of economic, financial capacity, but also you have to develop your own protocol. So you'll be guiding your doctor locally on the protocol, but also you have to consider evidence-based uh, studies on whatever to decide which one is there. We have also to consider supportive therapy by blood transfusion, platelet, and so on. So what are the indications to initiate the treatment to decide if the patient is for watch and wait or to treat? So you decide to treat a patient if there is a progressive marrow failure, there is a evidence of autoimmune hemolytic anemia or autoimmune thrombocytopenia with poor response to steroid. You may also treat if there is massive and progressive hepatomegaly and splenomegaly or even lymphadenopathy or rapid lymphocyte doubling time. So if you follow the patient for 1 year, today after 40,000, then after 1 year he has like 80. So you have to decide to start treating your patient. So this is the list of the medicine to be given with the antigen they are targeting. You have to consider rituximab as the first-line therapy for most of the countries that has shown a good response. Then you have to also to consider in which risk is your patient. Is it low risk? Is it intermediate risk or high risk? Considering the classification of Rai or Binet will help your patient to get which choice of the treatment to be given. So that is what we can say in summary. When you have the diagnosis, the patient is asymptomatic, you decide to watch and wait. Wait, you keep monitoring your patient, testing the full blood count, and monitoring him. If they become symptomatic, you have to good performance data. You have to assess the patient if he's having a good performance and the patient is okay. Then you should also decide to give corambisil or consider clinical trials. You can decide to give other medication depending on the protocol you are using on your local area. So that is all for acute leukemia. That is all for leukemias. Remember acute and chronic leukemia. Remember how to differentiate chronic from acute, but also how do we diagnose leukemia and what are the the differential diagnosis of leukemia and what is the management plan. Remember again, if you are dealing with leukemia, acute leukemia is the most severe one. You need to refer the patient earlier. So understand if your patient is coming having two things, alteration like a white cell increase or anemia. So if two parameter of the full blood is not normal, remember to consider leukemia on the differential diagnosis and refer the patient as soon as possible. The next malignancy will be lymphoma. We'll go quickly on lymphoma and lymphoma again. Are you seeing the slide?
Yes.
Okay, so lymphoma is a neoplastic proliferation of the lymphocytes, which now originate in the lymph nodes or other lymphoid tissues. So we have two major subtype of lymphoma. We have Hodgkin lymphoma and non-Hodgkin lymphoma. So what's usually what the difference between lymphoma and leukemia? They are really closely related disorder. It's just from lymphoma, the malignant cell rise in the lymphoid tissue, while in leukemia, it rise from the bone marrow. So lymphoma can start from the one of the lymphoid tissue and spread, secondary spread, but also we have to understand the number of the blast, which also differentiates acute lymphoblastic leukemia for non-Hodgkin lymphoma. So to have leukemia, you need to have at least 30% of the cell being blasts, which make the difference there. So we have Hodgkin lymphoma and non-Hodgkin lymphoma. We have in Hodgkin, we have two types. We have classical, which has nodular sclerosis. We have mixed cellularity. We have lymphocyte rich and lymphocyte depleted. Non-Hodgkin lymphoma, we have a large variation of the lymphomas, which does not fit the definition of Hodgkin lymphoma. Among the group, we have Burkitt and not Burkitt-like lymphoma. We have diffuse large B-cell lymphoma, and the rest. We say that we have more than 20 types of the lymphoma. So let's start with the Hodgkin lymphoma. Hodgkin lymphoma was first described by Thomas Hodgkin, 1833. It's one of the mostly B-cell neoplasma. Uh, the origin are not known, but it's usually it might have some associated factor like ABV virus, where they found people with the ABV history of ABV infection has 3 times risk of developing lymphoma. There's also association with radiation, so exposure to radiation causing high number of Hodgkin lymphoma. So predominantly in the incidence is like 200 new cases per 1 million of population per year. In Africa, there's non-age adult incidence, but comparing the ratio for non-Hodgkin to Hodgkin lymphoma, non-Hodgkin come 6 times more than Hodgkin lymphoma. The age is incidence mostly peak at the age of 20 to 30, but also can occur between 50 to 65. Studies show that there's somehow high prevalence more in male compared to the female. Clinical manifestation, how does someone with Hodgkin lymphoma present? Usually they have lymphadenopathy, which is painless, discreet, and firm. They may also have hepatosplenomegaly. Top of that, they may have B symptoms, fever, night sweat, and white loss. They have pruritus, but also they have something we call alcohol-induced pain when swallowing the lymph node. So when they drink alcohol, they feel like there is a pain on the lymph node. Among them, 35 will have anemia, eosinophilia, but also there's high risk of infection to Epstein-Barr, to herpes virus, CMV, and Candida. The lymphoma may start on one of the lymph node. Let's say usually classically it start from the neck, cervical lymphadenopathy, that is for the Hodgkin, then spread all over the body depending on the stage of disease progression. So we have the painless vertical cervical lymphadenopathy, which is firm, rubbery, which may be sensitive. 3/3 of them has mediastinal involvement, which may cause cough and bronchial compression. They may also have axillary or angular lymphadenopathy. So they're also associated with the systemic symptoms like fatigue, anorexia, weight loss, pruritus. Remember the fever and can also occur. So when you have lymphoma, you should be considering how do you stage there. After the diagnosis, of course, you have to stage the lymphoma. Here we are going to use an arbor clinical staging, which is focusing on the number of the lymph nodes seen. So stage 1, they have single lymph node region. Stage 2, two or more lymph node region, but all of them in the side of the diaphragm. Stage 3, we have 3 or more lymph nodes on both sides of the diaphragm. Then stage 4, we have disseminated diseases, which involve the liver, the bone marrow, and so on. Then on this annular bar, you have to add if there is a systemic symptom or non-systemic symptom. So you add A or B depending on the fact that the patient has a systemic or non-systemic condition. So this is the image we were explaining. So stage 1 is here, only one region left node on the neck. Stage 2, we have both region, but all the same side of the diaphragm. Stage 3, we have more than two, but both sides of the diaphragm. Then stage 4, we have disseminated lymphoma, where we see lymph node all over. You see that in stage 4, that's when the patient may have anemia as there is bone marrow involvement. So at the beginning, the patient may present with normal full blood count. I usually tell people when you see lymphoma, the diagnosis is not done on the bone marrow at the beginning. You can start by diagnosing the lymphoma, and bone marrow may be done when you are staging it, not like a preliminary diagnostic area. That's again the repetition. So how do you make the diagnosis of lymphoma? It's just by doing a excision and biopsy of the lymph nodes. Then when you get the biopsy, you confirm that the patient is having a Hodgkin lymphoma. You have to do staging of the lymphoma by doing chest X-ray, ultrasound, CT scan to see where are the lymph nodes, or you are staging to know is it the patient in stage 1, stage 4, and so on. You may also do what we call CT scan, but the PET-CT, positron emission tomography, is the smartest to just go there once. It show you where is the lymphoma cell localized. So PET-CT neo is advanced why you have it, but if you don't have it, you have to conform to the CT scan to see. So apart doing the staging, you also check the full blood count. It may show you anemia, which is normocytic normochromic. The patient may also have leukocytosis, but also leukoerythroblastic picture. Again, remember that may be in advanced case of lymphoma. Check the liver biopsy, check the full blood count, the renal function test, the uric acid, LDH, and so on. That will help you to see other organ involvement. Now, the histology, how do you confirm if it is a Hodgkin lymphoma? The red Sternberg cell is the characteristic diagnostic element, which is a cell in the cellular background of lymph node, eosinophil, plasma cell, and histiocytes. It's really the key thing to make you say that this is Hodgkin lymphoma. If you don't see red Sternberg cell, you're not dealing with Hodgkin lymphoma. So all the lymphoma where you don't see red Sternberg are classified as non-Hodgkin. So as I said, you have different type of Hodgkin. We have nodular sclerosis, which has poor prognosis. Mixed cellularity, which also have poor prognosis. We have lymphocyte predominant, which has good prognosis, then poor prognosis, and lymphocyte depleted. So again, these type of the cell are seen on the histology of the lymph node or the mass. So So the differential diagnosis of that, you have infection, which may be due to HIV, ABV, TB, and so on, or the non-Hodgkin lymphoma, or in case of lupus, also you may think about that. So how do we treat the lymphoma? First of all, you need to stage your patient, and you know in which stage is the patient. Stage 1 and stage 1A and stage 2B, meaning that they don't have systemic symptom. You have to give combination of ABVD, which is adriamycin, bleomycin, vinblastine, and dacarbazine combination, 6 to 8 courses plus radiotherapy. Then for the rest, you also combine chemotherapy and radiotherapy. Uh, Give me 1 minute. So we are still on the treatment. So let's see now the staging depending on the prognosis. So I said that the prognosis depend on the stage of the diseases. So meaning that stage 1 and stage 2 will have a better prognosis where 80% of the patient will cure, even more will cure completely. Then stage 3 and stage 4, the cure rate is around 40 to 70%. So again, what we can say compared to leukemias, lymphomas, when diagnosed at early stage had better prognosis. So this is a case of a huge lymph node due to non-Hodgkin lymphoma. The Redstenberg cell we are talking about, Redstenberg, are this huge cell you are seeing in the center, which has two nucleus. On the background, all the cells you see, you have a lymphocyte, you have a steatocyte, you have a eosinophil, and so on. So this is classical presentation of Hodgkin lymphoma. Here again, you see red Hodgkin cells here in the center and in background of other lymphocytic cells. So for the subtype we have said about it, the most common is nodular sclerosis, which is here on the center. On the first imaging, we have mixed celerity. Then you have either lymphocyte depleted or lymphocyte type. This is a abundant Redstenberg cell diffuse in this slide. The same images. That's more images on the Rendsburg cell. So now let's go to the non-Hodgkin. Non-Hodgkin again is a large group of clonal tumors. It represents 85 B cell origin and 15 either T or NK origin. They have a variation in the clinical and the history than the Hodgkin lymphoma, but even the pattern of the disease is somehow irregular because they may also have extranular disease which are more common. We have seen that Murray Hodgkin, it may start from the lymph node, from the cervical, it spread there, it go there, but Murray lymphoid tissue. But here you may see extranuclear disease are also more common. You may see lymphoma of the gastric, lymphoma on the central nervous system, lymphoma on the testes. So it may occur even in extranodular region. So all the lymphoma which not classified as Hodgkin are called non-Hodgkin. It may originate in the cell and organ of the immune system. It also somehow overlapping with acute lymphoblastic leukemia, pathologically and clinically. The risk factors are multiple. We have involvement of the virus. We have HIV-1, which is in high-grade B-cell lymphoma, CNS lymphoma. We have ABV in Burkitt lymphoma, in Hodgkin lymphoma, and so on. We have RTLV1, Helicobacter pylori, which is common in gastric lymphoma. We have hepatitis C, human herpes virus, radiation. All this, the group, are the predisposing factor for lymphoma. Then when you are dealing with non-Hodgkin lymphoma, you have to know that we have low grade and high grade. Low grade or indolent lymphoma are the one which they are really slow progression. They are not really aggressive. Among them, we have small lymphocytic leukemia, lymphoma, which look like CLL. When you go to the morphology, they're quite similar to CLL. They have follicular lymphoma, mantle cell lymphoma, or lymphoplasmacytoid lymphoma. For the high grade, they are very aggressive, and we have a diffuse large B-cell lymphoma. We have Burkitt lymphoma. So when they're aggressive, you even see the progression is very quick, and the size in the tumor on the lymph nodes, the size of the tumor is doubling or increasing quickly, then you may also see other type of the lymphoma which are classified as high-grade lymphoma. So we have also natural killer, which represents 15. Natural killer lymphoma has poor prognosis compared to the rest. So what are the clinical manifestation of non-Hodgkin lymphoma? We have the age. First of all, the peak is between in 50 years, but most common in older age. The predominance is male compared to the female. They have superficial lymphadenopathy, constitutional B symptom are the first one. Oropharyngeal involvement, they also may present with future of pancytopenia. Organ which may be involved, we have gastrointestinal, skin, brain, testis. So extranodal has been also reported to have involvement in the non-Hodgkin lymphoma. So clinical presentation for BL is Burkitt lymphoma. It's usually one of the non-Hodgkin lymphoma, which is somehow aggressive one. It occurs in boys at the age of 4 to 7 years. It usually, the swelling will be on the jaw, but also may affect the ear and the abdomen or paraspinal. Timing of the tumor doubling, it's like in less than 80 hours. You see the child today with size of the tumor, but after like hours, you see the tumor somehow doubling the size very quickly. It has high tumor burden, but also it can cause intussusception. It can also cause acute abdomen, spontaneous tumor lesions, renal failure, and so on. It may also have CNS abnormalities. Other sites can be represented like ovaries, skin, thyroid. So this is a young child with the Burkitt lymphoma. You see the jaw is affected mostly in 70% of the cases, but also you look on the orbital, they have orbital tumor, and they have maxilla involvements. So how do we classify it? As the classification is now from Seth Jude. The stage 1 is single extranodal or nodal tumor, excluding mediastinum or abdomen. Stage 2, single extranodal tumor with regional lymph nodes, more than 2 areas same side of the diaphragm. Then it can also have 2 single extranodal tumor, which may involve one side of the diaphragm. They may have primary GI tumor or mesenteric node involvement. Then you have stage 2, which has extranodal tumor, opposite side of the diaphragm. Then we have stage 4, which have any of the above, but they have bone marrow involvement and CNS involvement. Again, remember, bone marrow involvement is come out at the stage of stage 4. So at the beginning, there is no really the bone marrow involvement. So how do you make the diagnosis? Again, lymph node biopsy for histology, which will show you the definitive diagnosis. You have to do immunophenotyping, which will also show you the cluster of definition, which help you to differentiate either it is a B cell or T cell lymphoma. You have to do cytogenetic testing, which most of, for example, for Burkitt lymphoma, there is translocation between chromosome 8 and 14, but also to see molecular studies for more details. When you get your diagnosis, it's the same for the Hodgkin lymphoma. You have to stage your patient by doing other investigation, but we have talked about PET-CT, which is positron emission tomography, which help you to know where is the lymphoma cells across the body. Other lab, we have mentioned it, full blood count, LDH are routinely done, renal function tests are routinely done to see how it is going on. So now the treatment after After the staging is, as I said, the purpose of the staging is to know the prognosis, but also to decide the treatment plan for your patient. So the treatment plan now is based on the histological subtype of the non-Hodgkin lymphoma, but also on the grade of the lymphoma, but also on the stage of the diseases. If the patient is having low-grade lymphoma or high-grade lymphoma, decision to take would be either aggressive treatment for high-grade or slow-grade, also depend on that. So for low-grade non-Hodgkin lymphoma, stage 1 and stage 2, remember stage 1 and stage 2, there's radiotherapy. Then stage 3 and stage 4, you can give single alkyl agent like chlorambucil or cyclophosphamide, or you can give what we call CHOP. CHOP means you combine cyclophosphamide, you combine hydroxy, donoribicin, and oncovin together and prednisolone. Then for high-grade non-Hodgkin lymphoma, you can give also CHOP, but also you can combine other combination indicated for the subtype. Prognosis of lymphoma, stage 1 and stage 2, good prognosis. The cure rate is like even 100% almost. Stage 3, 90%, and stage 4, 85 to 90%. Then when there is a CNS involvement, the prognosis is somehow bad. So if there is CNS involvement. Bucket lymphoma, we have said it. That is again a bucket lymphoma. Bucket lymphoma, when you look on the bone marrow or on the biopsy, it look like L3 ILL. If you remember the L3 ILL with the vacuolation in the cytoplasm, that is how bucket lymphoma look like. It's just when you go to the history taking, you realize that it's not a leukemia, it's now a lymphoma. So, but one of those you see on the cell morphology, they look as it is the same. So apart the chemotherapy, you have to do supportive treatment, which focus on supporting blood transfusion, antibiotic in case of infection, and nutrition status. You can also give a single agent in case of Burkitt lymphoma, cyclophosphamide. Do well, but also you can give also COP, or you can give high dose methotrexate. So you can also do surgical resection for bulky diseases. Only diffuse and follicular pattern of non-Hodgkin lymphoma in the histology, it looks like that. The lymphoma also can spread to the bloodstream, to the peripheral bloodstream, and it look like a leukemia. Then you see the characteristic of the cells which are seen there. So now if you have a patient who has lymphadenopathy, what will be your approach? So the approach is to consider enlargement when it is above 1.5 centimeter in inguinal area, or 1 centimeter above on the axilla or cervical. So the location is important. You have to precise, is it localized or it is generalized? And you carefully take the history and the physical examination to help you to suggest the diagnosis. Among the differential diagnosis of lymphadenopathy, you have to think about infection, which include TB, typhoid fever, ABV, CMV, and so on. Consider autoimmune diseases like systemic lupus, then dermatomyositis. We have malignancies, which include the Hodgkin lymphoma and non-Hodgkin lymphoma. Consider also metastases like other posts from other cancers, leukemia, neuroblastoma, drug reaction, or lipid storage diseases. So these are the list of the differential diagnosis when you have someone with lymphadenopathy. Don't jump only on thinking about lymphoma, but also think about benign condition which may cause lymphadenopathy. So remember, when the lymph nodes are firm, fixed, they always suggest malignancy. But also if you are suspecting a bacterial infection, Then after the size does not decrease for 10 days after infection, you need to do further evaluation to exclude malignancy. So you need to monitor and document the size carefully. Then you perform biopsy if you're adapting. So that is all about lymphoma and leukemias. If you have any question, you can ask now. We can take a break of 10 minutes, then we come back. You can relax a bit. Then we meet after 15 minutes. Is it okay?
Yes.
So let's meet at 11:27, around in 15 minutes. I'll be back. Oh, are you back? You can continue. Are you back? Hello.
Hello.
Okay, we can continue. We can resume. So the next type of malignancy is what we call multiple myeloma. Multiple myeloma can be also called plasma cell dyscrasia or plasma cell myeloma. It's now malignant proliferation of the plasma cell. If you remember the plasma cell at the beginning, I show you that the plasma cell are the B lymphocytes after producing immunoglobulin. If you remember the image of plasma cell, then that's plasma cell usually will be producing either IgG or IgA are single type or identical molecular structure, which is called paraprotein. So you remember that there is four classes of immunoglobulin, but for multiple myeloma, the focus in production will be only based on the either IgG or IgA as a single component of immunoglobulin, what we call paraprotein. So it's also plasma cell can also call plasma B cell or plasmocyte or plasmacyte. They are those are just definition of B cells. So B cell which is producing immunoglobulin. So now the clinical manifestation of the multiple myeloma will depend on the property of the myeloma cell and the monoclonal paraprotein they produced. So if you remember very well, we have from the acute leukemia, we have acute lymphoblastic leukemia and acute myeloblastic leukemia. We have chronic lymphocytic leukemia, we have lymphoma, and we have multiple myeloma from the lymphoid side. So remember, acute lymphoblastic leukemia, chronic lymphocytic leukemia, lymphoma, and multiple myeloma are really on the lymphoid progenitors. Then from the myeloid cell, we have myelodysplasia, we have acute myeloid leukemia, we have also myeloproliferative disorder, which affects all the cells we have seen there. So the epidemiology of multiple myeloma, it's usually 1% of the all cancers, but represent 10 to 15% of all hematological liquid malignancy, which again it is the second most common cause of liquid malignancy. So the lifetime risk of getting multiple myeloma, it is 1 in 159. In the US, they have around 4,000 new cases by each year, and the annual incidence is between 3 to 50 cases per million. African American and Black from Africa has like 2 to 3 times high risk to develop multiple myeloma than in white. There is somehow slight more prevalence in the male compared to the female. Again, multiple myeloma occur at the age above 65. It's really, most of them occur more than 50, 90% more than 50, but less than 30% will occur below the age of 40. Recently, we have one case at Seashika of a guy with 35 years. So it's these of the old people, but it may occur less than 30% in young age. Age mortality by epidemiology, we have the table here show you that the multiple myeloma increase in black male depending on their age. So over 80%, you see that it's very high. It's lower, more Hispanic female, but also lower in Hispanic male. Maurice Ashka, we see around 10 cases per year. But again, this is long time ago. We may see now like even 30%, 30 cases per year. So the case number of the cases are increased. Uh, 13 patients were like 6 male and 7 female, and they were seen in hematology clinic at King Faisal Hospital, May 2011. The major age among our population was like 47.6, and the ranging from 36 to 85. The cause is not known, but there is a exposure to toxic agents that are being not involved. There is association with the herpes virus, but how this herpes virus causes multiple myeloma is not clear. The table here summarizes somehow risk factors. We have accepted risk factors which list like increased age, male sex, African American race, family history. Then you have history of having monoclonal gammopathy of significance. So we discussed about that. Then we have inconsistent data on the risk. We have possible risk factors which include obesity, HIV, herpes delta. Then the rest do not appear to be the risk factor like alcohol intake, smoking, and so on. So how is the pathogenesis of multiple myeloma? It usually, as we said, the B lymphocytes, they have abnormal response to antigenic stimulation. When there is a abnormal response to the antigenic stimulation, there will be increased number of monoclonal gammopathy of insignificance. Then from that one, there will be a genetic lesion which may cause some secondary translocation, oncogenic abnormalities, and they may also make increase in myeloma cells, meaning that increase in the plasma cell that will be the initial diagnosis of multiple myeloma. Then the multiple myeloma will be causing end organ damage like a lytic bone lesion, hypokalemia, renal function, and so on. So again, 50% of the condition might be just normal, but with progression, the monoclonal gammopathy may progress to multiple myeloma if uh, there's no follow-up. We need to do follow-up. So the myeloma cell will proliferate and make antibodies, many antibodies. The monoclonal antibody is called M protein, which can be identified either by testing the serum or the urine. Those myeloma cell has the capacity of producing osteoclastic activity, activating cytokine by tumor cell, which will lead to substantial calcium mobilization, hypercalcemia, and symptom related to it. So osteoclastic activity will be like bone destruction. On the marrow, there will be bone marrow infiltration, so the bone marrow will not be able to produce the red cell, the platelets, and the white cell. That will lead to future of anemia, future of bleeding due to decrease of platelets, but also susceptibility to get infection because there will be leukopenia. There will be, as we said, we have 5 group of immunoglobulin, but here in case of multiple myeloma, there will be production for one of the immunoglobulin, the IgG or IgA, but in excess, which will be like a paraprotein. That single immunoglobulin do not have any antigenic activity, so they will also predispose the patient to have high infection risk. So the most of the type is usually the abnormal hemoglobin that may produce like IgG and IgA. Then we have Benz-Jones protein, which will be produced in the kidney. And you have IgD and IgA are really very rare. So the myeloma cell have produced osteoclastic activity, which may make the osteoclast nibble away at the bone, causing lytic lesions on the bone that will be manifested by increased calcium. As there is a bone destruction, there will be increased calcium, and the bone will be fragilized, will be causing pathological fractures on the patient. So the symptoms of hypercalcemia include increased thirsty, polyuria, constipation, and colic abdominal pain. In the treatment goal, we need to focusing on regular rehydration, but also we have to consider high dose steroid and bisphosphonates group drugs to decrease the high amount of the calcium. So again, as there will be excess of production, there will be the paraprotein will be causing increased blood viscosity. That also will be an issue in multiple myeloma. The renal failure may also occur, which is really due to either hypoviscosity or hypercalcemia with amyloid deposition or deposition of free hemoglobin from the immunoglobulin light chains, which has nephrotoxic effects on the kidney. So what are the symptoms of a multiple myeloma? We say that the onset is insidious, then the age, it is really above the age of 50, with rare under 40. There is a female male predominance, but the commonest thing to see is to look at the bone pain, mostly on the back pain. Most of the patients, like 60%, will consult for the back pain. Then they may also have lytic lesion, which cause also they may have unexplained pathological fractures. Lytic lesion is seen in 80% of the cases. The patient will have recurrent infection due to neutropenia, but also hypogammaglobulinemia. Then the rest of the symptoms are consequence of bone marrow failure of producing those cells. Remember hypercalcemia with its symptom. Remember symptoms of hyperviscosity, but also peripheral neuropathy may also occur as consequence of pathological fractures on the vertebra causing spinal cord compression. So the patient may also present peripheral neuropathy. Plasma cell proliferation may cause pancytopenia, bone damage with constitutional symptoms, anorexia, cachexia, and hyperglycemia. We have monoclonal protein, which will also cause renal failure and immunodeficiency. So these are the symptoms we have said about it. Back pain, remember, back pain is the commonest among the manifestation. And here you can see the clinical manifestation of the bone diseases. It's usually affecting the spine. So that's why I said most of the patients will consult for the spinal pain, like 60%. Then 30% will on the skull, the femur, the pelvis. That will be really a problem. So they have bone pain, they have pathological fractures, hypercalcemia with spinal cord compression, which is somehow less. So this is classically the image on which bones can be affected. So the diagnosis of multiple myeloma is usually based on the clinical manifestation, blood test, and the bone marrow examination. So by definition, a plasma cell in the bone marrow should be below 2%, but in case of multiple myeloma, there will be increase of plasma cell above 10%. That is the definition from the bone marrow. The patient will have lytic bone lesions and may have a serum or urine M components, monoclonal protein components, which are the triads of multiple myeloma. So again, increased plasma cell above 10% in the bone marrow, having lytic lesions, bone lesion, then having protein electrophoresis showing M components are the three things pushing you to to opt for the diagnosis of multiple myeloma. The ECI will be very high due to hyperviscosity. Then the CRP will be also increased. So blood count and peripheral smear will be normocytic normochromic anemia, and sometimes it may be also normal, but the peripheral blood film will show you what we call rouleau formation. I think I'll show you what does the rouleau formation look like. It's just the red cell coming together, forming like having the form of the rouleau coming together on the same. Then we have leukopenia, thrombocytopenia, and it's rare to see the plasma cell in the peripheral blood film. Normally, the diagnosis is made in the bone marrow. So this is the rouleau formation we are talking about. You see how the red cells are coming together like a rouleau. You can see there in the peripheral blood film. Then the next test is to do serum protein electrophoresis, which will demonstrate the band on the peak of M protein in 82% of the patients with multiple myeloma. You can also do serum protein immunofixation, which will be more sensitivities. Then we can also check for the serum free light chain on electrophoresis and immune immunofixation, which has more sensitivities. So this is electrophoresis in the case of multiple myeloma. You see that that is the normal one. Then you see a peak here in immunoglobulin. Bone marrow aspiration show really it's a key component to the diagnosis, where you'll be focusing on counting the number of the plasma cell, which may show you a high number of myeloma cell, increased number of the plasma cell above 10%. So that is the definition of the disease. So you may also see the number of the plasma cell less than 10% in few patients, around 4% of the patients. So this is the image of the plasma cell. You see, this is how you look at the bone marrow, increased number of plasma cells. The plasma cells are large cells. They have eccentric nucleus with the perinuclear pale zone. Behind the nucleus, you see that there is a whitish region which is pale there. That is a plasma cell. When you see the number above 10%, that meets the definition of multiple myeloma. You can also see the images in the urine analysis, where you'll be looking for the Burns-Jones protein, and you can also do immunophenotyping. And while going to the imaging, you will see the imaging are really very important to screen for the lytic lesion. What we call, you have to do skeletal survey which show you lytic lesion, especially on the skull. You have to do CT, PET CT, and MRI if necessary. So this is an image showing you you see how the lytic lesion look like? You see on the skull, we call it patch out lesions. When you see things like that, remember to do screening to a bone marrow to check for multiple myeloma. So on the laboratory, we have some criteria to make you fit the diagnosis. You have at least two of the following criteria. We have monoclonal protein in the serum. You have osteolytic lesions, but also presence of 10% of the plasma cell in the peripheral blood film. Other investigations are just accompanying what we have already said, calcemia, ASI, and so on. So what are the complications of the multiple myeloma? Remember renal failure, increased susceptibility to infection due to leukopenia and gamma globulin. We have rise of calcium, bone fractures, neurological issue due to paralysis from the tumor or spinal cord compression, hyperviscosity, anemia, and thrombocytopenia, and infection may also be among the complications. Among the differential diagnosis, we have monoclonal gammopathy of endothermic significance. We have smoldering multiple myeloma. We have Waldenstone macroglobulinemia, solitary plasmacytomia, and the rest. So we'll go through all these differential diagnoses shortly. We understand more about that. So the diagnostic criteria now is practical. We have what we call monoclonal gammopathy of undetermined significance, which is here. There is decrease less than 3 grams of monoclonal paraprotein peak. Then you have plasma cell below 10%. Smoldering multiple myeloma, we have M protein above 3 grams. Then you have increase of plasma cell above 10%. Active multiple myeloma, you have 100% of the plasma cells. So 10% above of the plasma cell with M peak of any size, but also you have what we call crab criteria, which will be positive. So crab criteria means you have a high calcium, you have renal dysfunction, we have anemia, then you have bone lytic lesion, where you have also hyperviscosity, amyloid, and recurrent infection. That will be active multiple myeloma. Then these two, my active one is just when you add crab criteria, which is somehow positive. So smoldering multiple myeloma in here indifit asymptomatic, it fit crab criteria, so that's how we can say it. Then you can also have smoldering multiple myeloma, which can progress to active multiple myeloma. So treatment indication is to treat it when there is a anemia less than 10 grams per deciliter. We have to consider also treating hypercalcemia, if there's hypercalcemia or if there is renal insufficiency, but also lytic lesion involved. So they have two goal of treatment. We have supportive treatment, which include like rehydrating the patient, giving bisphosphonate to decrease the calcium, giving blood transfusion components, treating the infection, and so on. Then the second will be uh, chemotherapy. So, my supportive care, we also understand that the patient, if he has severe renal failure, he may need dialysis, but also he may also have fractures, pathological fractures, which can be fixed by the orthopedic surgeon. So it's like a multidisciplinary approach where you will be assisting by the surgeon, the hematologist, the nephrologist to address the dialysis. So it's really a multidisciplinary thing. So the patient will be starting chemotherapy, which in the past considering giving melphalan and prednisolone. But now on the market, there are really new line of treatment, which is more advanced, and it has also several approach. You can go for thalidomide, adding dexamethasone. Then dexamethasone can also be given like 4 milligram per day for 4 days. Then you repeat it every month. Uh, there are also some group of the treatment which give bortezomib, adding it with dexamethasone, vincristine, and so on. Uh, you can also give vincristine, adriamycin together with doxorubicin, and you add dexamethasone. For if this treatment does not work, you can also opt for stem cell transplants. It also minimizes the risk of hematological toxicity, but it's just to support the chemotherapy you are giving. So we said that most of the patients with multiple myeloma are really in advanced age. You can't give it for people who are above 77 years, or people who have other associated comorbidities like heart failure, like cirrhosis. So those are the contraindication of stem cell transplantation. As again we said, uh, the regimen of chemotherapy is somehow countrywide discussed, and the protocol discussed depending on the financial, depending on the availability of the medicine. The better you go to a developed country or a lower setting country, the protocol may be different, but what you need is just to have the overview of the given chemotherapy, uh, the side effects, and the outcome of each of them. Iyo ni protocol ya Butaro batanga. We have melphalan, but this day it's not advised to give melphalan. They are now going to the VADs, and also they can also opt for the single agent like a dexamethasone, repeating it for some cycles. This is the protocol for Butaro. So that means this protocol it's launched locally. If you go in other countries, you cannot see it. So countryside decided. So when you are treating multiple myeloma, you need to do some control like monitoring the renal function tests and full blood count. You can also repeat serum protein electrophoresis every 3 months, but also repeat bone marrow or aspiration every 6 months to see and to assess the response to the treatment. So there is somehow improving survival after advocating some more chemotherapy agents, where you see from the 1960 there were poor prognosis, but plus the age advancing, we see that there's somehow longer survival time on the multiple myeloma. So, in summary, what can we say? It's just to understand that multiple myeloma is present in our country. Uh, it usually has a peak in mid-age Black population, and the diagnosis criteria is combination of clinical and imaging studies. It's not curable condition. The patient may stay for the treatment for life treatment. It is sensitive to chemotherapy, but also the mortality chances survival time has somehow dramatically increased after uh, considering the use of diverse chemotherapy agents which are on the market. So someone with anemia, back pain, raised ESR, lytic lesion, remember multiple myeloma. It's among the diagnosis. So you see renal failure, bone pain, anemia, age of the patient. On the top, put also multiple myeloma. So the second diseases, which is also has some relation with the multiple myeloma, it's what we call the Waldenstrom macroglobulinemia, which is a chronic lymphoproliferative disorder. Here again, there's a proliferation of the cells which are somehow intermediate between the plasma cell and small lymphocytes. So the cells are classified as lymphoplasmacytoid lymphoma, as the cells which are there as have somehow morphology between lymphocyte and plasma cell. It's of the B cell, and the cell, as I said, it's between lymphocyte and plasma cell. It has a static nucleus as plasma cell, but they are larger. They're not larger. It secretes IgM plasma protein, while multiple myeloma secretes either IgG or IgA. So first of all, the the paraprotein, the immunoglobulin which is secreted is IgM compared to the plasma cell. So it is 7 times rare than multiple myeloma. The incidence is on that, and the major age is the same. Then there is a decrease. There is a rare case below 40 years. So on the clinical manifestation, the patient may have asthenia infection. They may have future of hyperviscosities like uh, the one seen in the multiple myeloma. They have hemorrhage. They may have neurological changes, heart failure. They may also have bleeding due to vascular congestion and so on. Other features are similar to chronic lymphocytic leukemia. We have seen it. They might have pleural effusion. They may also have diarrhea. But compared to the multiple myeloma, they don't have hypercalcemia or osteolytic lesion, which are seen in the multiple myeloma. So when you go to the bone marrow evaluation, you will see infiltration of the lymphocyte. You have a plasmacytoid lymphocyte, and you have few plasma cell and master cell which are prominent. The diagnosis, you go through the same process as multiple myeloma. You can see rouleau formation, you can see raised eye cell, you can also see increase of lymphocytes. Then you have monoclonal components, usually immunoglobulin M. Then you have little modification on hemoglobin, immunoglobulin IgG and IgA. So the survival time is 5 years. Then you have factor of the bad prognosis when it's associated with anemia or age of the patient, or also uh, if there is a cytopenia or not. So the treatment, you only treat when it is symptomatic. Uh, you can do plasmapheresis, which if there is a future for hyperviscosities. The treatment is the same as chronic lymphocytic leukemia, where you can give a chlorambucil, cyclophosphamide. You can also consider fludarabine. So the treatment consider the one used for chronic lymphocytic leukemia. Lastly, we have not lastly, we have a plasmacytoma. Plasmacytoma, it's a kind of tumor now, which is composed by the plasma cell. So the plasma cell has localized the position of the plasma cell as tumor or fracture. Now there's no paraprotein which are secreted. Uh, the bone marrow examination does not show plasma cell infiltration. So it's like a localized tumor on the body which is composed by the plasma cell. So when you do your X-ray on the plasmacytoma, you see like a soft bubble appearance on the X-ray. So the treatment it's usually incision with the local radiotherapy. Then sometimes many patients with the plasmacytoma may have a spread and develop what we call disseminated multiple myeloma. So it may start by plasmacytoma and go to multiple myeloma. And the next one is what we call benign monoclonal paraprotein gammopathy, which is somehow increased in the age of 60 to 50, 50 to 60. It's this paraprotein can be a manifestation of the myeloma or other B-cell lymphoproliferative disorder, which is usually having no clinical evidence. That's why they call it monoclonal gammopathy of uncertain significance. So there is a paraprotein increase, but really don't causing any clinical manifestation. Here, the serum monoclonal protein is below 10. Bone marrow plasma cell is below 10%. There is no end age organ damage, which is compared to the plasma cell or B cell lymphoproliferative. So there is no clinical manifestation. Then most of the cases, this condition may precede multiple myeloma. Then most of the patients with this MGE2 may not develop plasma cell dyscrabia, which require therapy. So for here, they have low concentration protein, they have a low level of other immunoglobulin are preserved, meaning that even if they have secretion of IgG, but the others are somehow produced in their sites nicely. They don't have clinical manifestation of plasma cell, and again, we recommend that those patients should be put on follow-up and review as regular basis because they may develop multiple myeloma. 30% of them may develop multiple myeloma. That is why it's good to have follow-up on them. Lastly, we have a condition called plasma cell leukemia. It's usually defined by plasma cell dyscrasia, where you'll be having spread of the plasma cell to the bloodstream. So you may see now. I saw that in multiple myeloma, it's somehow rare to see the plasma cell in the peripheral blood film, but in plasma cell leukemia now, the bone marrow is full of the plasma cell and spread it to the bloodstream. So you'll be seeing circulating plasma cell around that number and represented at least 20% of circulating cells. So they may have usual clinical manifestation of multiple myeloma, but they may also have likely to have extramedullary lesion like hepatosplenomegaly. Then the prognosis is poor compared to multiple myeloma. It's like it's somehow the progression of the diseases, then being worse than the one of bone marrow. So those are just the definition I put on. So this is all for leukemia, lymphoma, multiple myeloma. The last topic will be focused on. Then you can ask the question after this. Let's go quickly on. We can have like 15 minutes before we go for break. We can continue for 15 minutes. Myeloproliferative disorder, if you remember, we have somehow explained it a little bit before, but now let's go in details. So it is a, first of all, myeloproliferative mean one of the myeloid lineage. We have a granulocyte lineage, we have erythroid and megakaryocytic. So except the lymphocyte, which is out here, but all of the cells are considered. So it's a clonal hematopoietic disorders, which will focus on proliferation of one of these cells here. Then here again, there will be the cell will be relatively maturating well. So WHO classification classified in 4 groups. We have chronic myeloid leukemia. Secondly, we have polycythemia rubra vera. We have ancestral thrombocythemia, and 4 we have myelofibrosis. So these are the 4 groups of myeloproliferative disorder. So myeloproliferative disorder may have some component of chronic myelomonocytic leukemia having a relation with myelodysplasia, but also myeloproliferative disorder has also somehow relation with the acute myeloid leukemia by having a chronic myeloid leukemia here in intersection. But what they have in common being myelodysplasia or myeloproliferative, they may also progress to acute myeloid leukemia. So being the 4 groups, we are going to see each of them. We have already covered the chronic myeloid leukemia. This is the bone marrow stem cell, how it's presented like this. For the granulocyte precursors, they'll have a chronic myeloid leukemia. For the red cell precursor, they'll have a polycythemia rubra vera, meaning excess in production of the red cells. For the megakaryocytes, they will have ancestral thrombocythemia. Then lastly, there will be myelofibrosis. Myelofibrosis can be also the development of all these conditions. We have increase of white cell, increase of red cell and platelets. The bone marrow has been active for a long time, then it may change and becoming fibrotic. So the fibrosis can also coming from there. Then you have also the transformation of the disease course. So chronic CML may change to acute myeloid leukemia in 70% of the cases. Polycythemia rubra vera in 10 cases of the cases. Then myelofibrosis also in 10 cases of the cases. So again, polycythemia rubra vein L and the myelofibrosis can also turning to myelofibrosis from P vera, 30% may become myelofibrosis.
Sorry,
Sure, yeah.
you said you said the chronic myeloid leukemia can turn acute. How?
So among the transformation, we said that Mori acute, if you remember the phase of CML, we have classified them in 3 phases. We have chronic phases, we have accelerated phases, and you have blastic phases. So blastic phases is how if you don't treat the CML on the disease progression, it may present as acute myeloid leukemia, where you'll be having increased number of the blasts, which will be above 20%, but by this, it meets the requirements or the definition of acute myeloid leukemia. It's a progression of diseases if there is no treatment. Is it clear? Did you get the answer?
Yes.
Oh, so let us start with the essential thrombocythemia or essential thrombocytosis, which is a primary thrombocythemia. It's a condition where there will be overproduction of the platelets without any evident causes. So among the risk factors, it's a slow progressing disorders which may caused by overgrowth of type of the cell, which are precursors of the blood cells. Uh, Most of time, it's the platelet which is affected, but the rest of the cell may also be affected, like a red blood cell and white cell platelet may also affected. Essential thrombocythemia usually affect people in the mid-age, but also it may occur despite having a high number of the platelets. Those platelets may develop what we call platelet dysfunction. So despite being high, they are abnormal in activity, so they may have a presentation of the bleeding. So the patient may bleed from the GI, from the urinary tract, and so on. So that is just, it is a chronopolymyelopoliferative disorder. Normal platelet count is between 150 to 400. So now there will be persistence of thrombocytosis above 600. Mechanism poorly understood, but it's somehow 2.5 cases on 100,000 of people. It's rare above 20. So most of the condition is above 60. So the patient will having increase of the thrombocytes. So they may have a headache, which represent as hyperviscosities. They may have thrombosis and hemorrhage. Why they have thrombosis? So I said that there will be increased platelet count. So they has high risk of developing thrombosis, but also they are bleeding because sometimes those platelets has platelet dysfunction, so they may cause the patient to bleed. Uh, we have seen the risk of transformation to acute myeloid leukemia. Around 10% of them will change to it will be transformed to acute myeloid leukemia. That's when you've said it. How do you make the diagnosis of essential thrombocythemia? You go for first of all, the full blood count will show you increase of the platelet count. There will be increase of uric acid, but when you do a physical examination, you may see enlargement of the liver, enlargement of the spleen, and the bone marrow will show you increase of the megakaryocytes in the bone marrow. That will be somehow orienting you to the cause of the essential thrombocythemia. So essential thrombocythemia is a diagnosis of exclusion after really excluding other possible causes of thrombocythemia. Among them, this is the list. You'll see it in details. Those are the condition which is not which can cause the platelet count to increase. And you wanna doctors just seen a platelet of 600 without investigating the patient, sending him to hematology. So platelet count can increase in case of infection, in case of TC damage after surgery, in case of chronic inflammation, malignancy, renal disorders, hemolytic anemia, and so on. So, if you do splenectomy to someone, you may expect him to have increase in platelets. So, essential thrombocythemia, it will be the diagnosis after this, excluding all these. Even iron deficiency can cause increase in platelets. You may see commonly increase of platelets in patients with iron deficiency. So diagnosis criteria is based on the platelet count above 600 for at least 2 months. When you do bone marrow, you see megakaryocyte hyperplasia. Then you don't see any reactive cause of thrombocytopenia like infection, like bleeding or iron deficiency, so on. You also see absence of Philadelphia chromosome. Then you go also, there's no evidence of myelofibrosis. The iron is okay because, as I said, the most common of thrombocythemia is also iron deficiency. Then there is no other obvious cause of myelodysplastic syndrome. So this image also show you what to do when you see someone with thrombocytosis. You think about reactive causes, cardiovascular infection, bleeding, iron deficiency. If it's identified, you treat the underlying condition. If it's not identified, you determine the duration of the thrombocytosis. If it is chronic or acute, if it is a non or chronic, you have to check iron and you have to check the CRP and C. If it's low, it may contribute to iron deficiency. Then it also, if the spleen is not there, hypofunctioning of the spleen, it also inflammatory process also should also be determined. So if it is an acute one, you have to consider also a reactive one, but also you can also then, if there's no clear causes, you proceed to the bone marrow. That the bone marrow will tell you if there is any future of essential thrombocythemia. So this is the image of the platelet in the peripheral blood film in this slide. Then on the right one, here is a bone marrow where you see the picture of megakaryocytes, which are somehow hyperplastic megakaryocytes. So in this image, you see quite increased number of the megakaryocytes, which really orient you to the diagnosis of essential thrombocythemia. So the treatment of essential thrombocythemia is usually based on the risk of developing thrombosis. We have low risk, high risk, or intermediate risk. When there is low risk, you have, for assessing the risk, you consider some factors like age below 60 and no history of thrombosis. And if there is extreme thrombocytosis above 1 million, or if there's a cardiovascular risk or like smoking or hyperlipidemia, that also should be considered as a high risk. Then middle risk, you consider like age above 60, or there's history of thrombosis, so that is median. Intermediate risk. Then low risk is those who don't have any of the present things, so they don't have any of all those things. So those are classified as very low risk. So if the patient is high risk or low risk, that's help you to decide how you have to do CO reduction with the hydrea or not, or you have to consider to give aspirin to prevent platelet aggregation. Uh, so most of the platelet count can be achieved to platelet pheresis, which is a procedure to remove the platelet from the blood. But if it is not okay, but also when you assess the risk of the patient, if he is having high risk, you have to consider adding CO reduction by giving some anti-alkyl like hydroxyurea, interferon alpha, and so on. Aspirin is given to reduce the risk of bleeding, also the risk of thrombosis. Uh, from the complication and outcomes, the patient usually report a prolonged period without any complication. The disease, the high mortality may either due to hemorrhage or thrombosis, which are the fatal complication of incestual thrombocythemia. So remember complication, severe bleeding, thrombotic event, transformation to acute leukemia or myelofibrosis. Second type of myeloproliferative disorder is idiopathic myelofibrosis, which is usually primary myelofibrosis disorder, where the bone marrow is replaced by the fibrotic tissues that without any evident causes. So there will be progressive scarring of the bone marrow occur that will be making the bone marrow unable to produce blood cell that make the hematopoiesis to take place outside of the bone marrow, in the liver or in the spleen, which may cause enlargement of which may cause hepatosplenomegaly. So the cause of primary myelofibrosis is not known, but usually develop above the age of 50. It leads to the progressive, as we said, the bone marrow is replaced by fibrotic tissue, so there will be poor microenvironment in the bone marrow, making the hematopoiesis to be poorly produced. So there will be decrease in white cell production, platelet production, but also there will be anemia. The disease may progress in worse in most of the case, but also the risk factors are not known. The patient will present future of anemia with fatigue, malaise, and so on, but they will be presenting also future of abdominal fullness due to enlargement of the spleen because there will be extramedullary hematopoiesis. There will be enlargement of the spleen. There will be future of bleeding, future of bone pain, and shortness of breath due to anemia, but also risk of high risk of infection because they decrease white cell production. Sign of them symptom. Physical examination will be focusing on the looking for the anemia, organ enlargement like liver, spleen, but also when you go to the investigation, you'll see on the peripheral blood film where you'll see what we call teardrops shaped cells, which is just the change in the red cell morphology, looking like a tear in the peripheral smear. That's why they call it teardrop cells. So the platelets and the white cell count may be variable, but they have tendency to be decreased. The bone marrow biopsy is the key to know the degree of the fibrosis. It may show you that bone marrow is fibrotic at which level. Then this complete blood cell will tell you the details. So how do you treat the primary myelofibrosis? Usually the blood transfusion is given to correct the anemia. You may give erythropoietin to stimulate the red cell production, but sometimes the splenectomy may be done in case there is a symptom of hypersplenism or you can also give radiotherapy and chemotherapy. So if the patients are still very young, in case you can also they can be the candidate to do bone marrow transplant, which improve the outcome. Lastly, the survival time of the myelofibrosis is around 5 years. Some of them may live for decades, but it's really a debilitating illness where the patient will be following for repeated blood transfusion. Then they may also transform to acute leukemia. So I think we can stop here and resume at 2 o'clock, going through the remaining part of the course so that we can finish today. Do you have any question?
Question.
Yeah.
So, how do you define the essential thrombocythemia? Because as acute, because I've seen that during the diagnosis, we consider to be it when it is at least 2 months. So when you say it's acute, when does it being acute to proceed with the bone marrow biopsy? Yes.
So acute one definition of essential thrombocythemia, it's when it is like above 3 months, it's there above 2 months, 3 months. Then in acute one can be due to either infection. What is the infection? Thrombopoietin is among the positive reactive protein. It may raise and it may increase production of the thrombocyte. So acute one may come in the context of infection. A chronic one is the one mostly due to essential thrombocythemia because it is there despite having any cause evidence. Then it keep persistent. If you don't do anything, the count will remain higher. So now it's not easy to know if it is a acute one may come in the context of all this we have said, infection, bleeding, and so on. That's why you decide this is acute. Then after that, you have to make follow-up on the patient. Does the thrombocytosis came to normal range now? Is it normal platelet count now? But when the patient is having ancestral thrombocythemia, the count will keep raising for a long time. Then you have to exclude other possible reactive causes to make sure that you are dealing with ancestral thrombocythemia. Yeah. If there's no question, we can stop there and we meet each other at 2 o'clock. Let's be on time because we need to finish the course today. There's still a lot to do today, but I hope we'll cover most of the things important. Thank you.